Hello again. I'm Dr. who now shows America's healthcare crisis. The title for our production tonight is The Quality Issue in Cardiovascular Surgery. This is part of a series of productions during which I have the opportunity to interview and profile the clinical champions in different medical specialties. The clinical champions are the physicians who, by virtue of their knowledge, their experience, and their integrity, are in the position of telling us what is considered quality medical services in their field of expertise. And tonight we are talking about cardiovascular surgery, and I'm very pleased to have with us two prominent cardiovascular surgeons in our community, and I'd like to introduce them. Dr. Fogarty. Hi, Dr. Fogarty. How are you tonight?
Good evening.
Thank you for coming to our show tonight. Welcome to our show. Dr. Fogarty is a pioneer in the field of cardiovascular surgery and has been a major contributor into the field. He is a full professor of surgery at Stanford University and has contributed as a teacher, a researcher, of course, is a performing surgeon with great skills, an author and an inventor. He has authored numerous articles which have been published in many medical magazines as well as journals and textbooks. And he also is the inventor of 54 surgical instruments, and I'm very honored to have him here with us tonight. Our second speaker is Dr. Sharon Bogerty. Bogerty? Bogerty. Dr. Bogerty went to medical school at Stanford and was also trained there in the field of cardiovascular surgery before she went to practice at O'Connor Hospital in San Jose. And she beside being a practicing physician, has also held prestigious positions as in the leadership capacity in different organizations, and I'm very happy to have her here with us tonight. Thank you for being here with us. So, Dr. Bogerty, can you give us a summary of the history and evolution of the field of cardiovascular surgery and maybe the latest developments?
I think at first it's well to define cardiovascular surgery because there's often confusion about what that specialty is. Mm-hmm. When you say cardiovascular, cardio usually refers to the heart. Mm-hmm. Vascular refers to the peripheral vascular system, your arteries and your veins. And the same surgeon may at times do both of those procedures, but often the surgeon will specialize just in the cardiac end or the vascular end.
I see.
That being said, they're very closely related specialties. And the history is relatively short by the criteria of medical history. It can really be divided into two 30-year periods. The first 30-year was a period of diagnostics where we learned to diagnose the disease. And when that really came to clinical utility, in other words, we can establish a diagnosis and do something about it, it really started in the 30s where we injected dye into the vascular system and could see the arteries. Mm-hmm. And that was the first real diagnostic event that allowed us to understand the pathology and then treat it. And then we had, carrying that on to the situation where the physician could actually diagnose cardiac disease by putting catheters into the various chambers and measuring pressures. Once having done that, that allows us to understand the defects, both congenital and acquired, that existed in the heart. Then we came to the era where we actually could access the vascular system, and that was done by a technique called the Seldinger technique of physician. The interesting aspect of that diagnostic era, it kind of ended in the 60s, but the various specialties included cardiologists, radiologists, and surgeons. Mm-hmm. Then we entered the area of therapeutics where we could actually treat the disease, and that started really in the early 60s, both when you're addressing the cardiac end and the vascular end. Mm-hmm. And once again, the people who contributed that were representative of different specialties. Probably the most significant event was that we learned to use what we call cardiopulmonary bypass, where we could actually support the patient's circulation, exclude the heart, and operate on the heart. And that really came to clinical utility in the late 50s and early 60s. So that really put us into the therapeutic era of cardiovascular disease, and that we could manage the disease and direct therapy at it.
Okay. What are the latest developments that you have been personally involved with?
Well, the latest developments, both the vascular and the cardiac end, is the ability to do procedures in a less invasive way.
Right.
And that applies both to the vascular and the cardiac end. An example in the vascular is that instead of opening the body to repair the blood vessels, we access the blood vessels by a catheter technique, and then we either, by that catheter, clean out the artery,
Right.
or we will place a stent or a stent graft in the artery.
Right. That's called angioplasty, right?
Well, that angioplasty is one form, but all of these are catheter-mediated therapeutic interventions,
Okay.
where we either take the offending material out, or we displace it by a balloon, that's called angioplasty, or we actually line the inside of the vessel with either a stent or a graft.
Okay. Now, Dr. Bogerty, I'm very interested in asking you about the aspect of training in cardiovascular surgery. You entered the residency in the 70s or the 60s?
And 70s.
70s.
You want me to make...
How many applicants competed for how many positions?
Well, it's hard for you to know that. As a resident, you don't find that out. You just are happy when they say yes. But basically, the training is comprised of the fact that you attend medical school. And in my case, I went on and did internal medicine for 2 years. And after that, I decided I liked, as Dr. Fogarty said, doing interventional work instead, and applied and came back to Stanford. And basically, in cardiovascular surgery, you do both the general surgery, so I'm board certified in general surgery, as well as the cardiac and thoracic and vascular aspect. Like you said, a lot of surgeons do one or the other, and in my case, I was fortunate to be at Stanford with Dr. Fogarty and Dr. Shumway, so I was trained to do all three.
What I was interested in is the competition for the slots there. I mean, because, for example, recently, I don't know about cardiovascular surgery, but for ophthalmology, at least 500, 1,000 people competed for 3 slots. Oh, what about cardiovascular surgery? I am not aware of.
Well, I couldn't really tell you the numbers. Dr. Fogarty could probably tell you better, but from the point of view of the resident, as long as you get your number called, you usually don't worry about who else was competing.
How many applicants for how many slots?
The cardiac program, I would say they have probably 70 serious applicants a year.
Oh, 70.
You know, for that particular position, and they end up taking 2.
I see.
For the vascular training, it's probably an equal number, 70, and we end up taking 1.
I see. I see.
But I think the specialties are still highly sought after, but probably not as much as they were in years earlier.
I see. And what was it like? How many years was that you trained in the field?
Well, when you
had to have a general surgery residency first.
Well, most of the time, yeah, you do general surgery as well as the cardiovascular and thoracic aspects. And that's about 9 to 10 years after medical school.
I see. And actually, you had, I don't know if you mind answering this question, it's rather personal, but you had 2 biases against you, your gender and your race, and you got in anyway, so you must be 4 or 5 times brighter than the other.
I wouldn't really say that.
No?
Not, you know, at the time, it was unusual to have women in surgery, and it still is. And I think that's not so much because of gender as much as partially lifestyle. And I was fortunate because I got out of college relatively young, and so I was able to get in medical school and then go straight through. But for a lot of women, for example, if you had young children, it would be very difficult to do the residency. And at the time, there were not a lot of minorities in medicine, but I didn't feel that you had to be better. I thought you had to be just as good as your colleagues. So I didn't really find it was a real problem, per se. I think probably by that point, you know, when you've already gone through medical school, it's probably less of an issue as when you're, say, starting to apply to college or applying to medical school.
Yeah. Well, what is the landscape of cardiovascular surgery like this? I assume as a GP, I don't know much about the intricacies of a specialty, but I assume that you have mostly surgeries having to do with coronary artery diseases, and then valvular diseases, and then maybe cardiac congenital anomalies. And the vascular aspects of it is probably related to atherosclerosis. Is that correct? So that's about sums it up?
Yeah, that really does sum it up. That's about and then you have trauma.
Right, trauma, yeah.
But the things you mentioned in addition to trauma pretty compromise most of what we as vascular and cardiac surgeons do. We're sophisticated plumbers.
How is managed care interfering with the landscape of cardiovascular surgery? Are you going to have to submit a whole bunch of requests and we get authorization from a business manager to do surgery?
Yeah, I think, you know, we've been dealing with that so long, it's almost no longer an issue. Other than you find that it encumbers your support personnel, and sometimes you, very significantly. It puts another interface between you and the patient. And so often, because the intermediary is paying the bill, unfortunately the surgeon or the physician sometimes are responding not to the patient but the insurance company.
Yeah.
Which is not the way we were taught, and probably not the way it should be.
Right. I'm actually very concerned about the fact that the business community is really dominating and controlling the delivery of care, and we are really playing on the sideline. Do you have any comment on that?
I think Tom makes a good point that by the time patients get to us, they've already gone through several layers of doctors. So rarely do we get a rejection, for example, of something we request. Like you said, it just adds another layer of bureaucracy, which really slows down the time, or if we want to get a CAT scan or we need to get an angiogram, nobody's going to reject it, but it means that's another 4 or 5 days or time that someone's spending calling in for that's not being devoted to patient care.
Yeah.
So it's something that we have to address. Like you said, we've been doing it for so long, we're used to it, but it does take a significant amount of staff time and doctor time that probably could be better spent on taking care of patients, or in his case, teaching in the university.
Now, I was watching a program on the national television show called Dateline, and it was openly reported that up to like 300,000 angioplasties annually may not be necessary. You might comment on that. Some of your colleagues at Stanford were featured in the show also. Did you have a chance to watch the show?
No, but I mean, that whenever there's a procedure that we do, as we do the procedure, we identify some situations where it's not as utilitarian as we thought it would be. But you can only discover that by doing it. And so you can say retrospectively that was unnecessary, but you would never know that until you in fact had done it. And also in terms of what one defines as unnecessary or necessary. I mean, is it a lifestyle? Is it life or death? Is it a matter of patient comfort? All those things could be defined as necessary or unnecessary, and then it all depends on from whose perspective.
Well, my understanding was that there were other options, and the cardiac surgeon involved went in the limit too quickly without considering other options?
Well, that's coronary bypass surgery.
No angioplasties.
Well, that's the cardiologist.
Oh, cardiologist, okay.
We take no blame for that.
Okay.
Yeah, we are surgeons, and for better or for worse, are not involved in angioplasty.
Oh, I see, okay.
We are involved in direct surgery. In other words, we put in new tubes. The cardiologist does catheter-mediated therapy, and they do what they call the balloon angioplasty.
Right, right.
And there has been identified, I think now, retrospectively, situations where that procedure of balloon angioplasty is not as effective as we had hoped it would be. But you can only make that determination after you, in fact, had done it.
Yeah.
And I think that's what has happened.
Yeah.
You know, with the cardiologists, I think they're now recognizing that perhaps this should not be applied as broadly as they had hoped
Right.
it could be.
Now, one of my guest speakers, who is an internist, said that there is really no data showing how many patients are still alive 1 year after coronary artery bypass. Is that true?
Oh, that's definitely not true.
Oh,
There have
okay.
been numerous studies done on how many patients survive. Mortality and morbidity statistics have always been a part of surgery, and probably cardiac surgery has been under more scrutiny, like Tom said, because it was a later developing specialty than any other.
I see.
And I think one important thing he points out, there have been numerous studies from the CAS study at the VA to more recent studies where when you want to assess how valuable surgery is not just could the person have surgery or not, but also do they go back to work? Are they now productive
Right,
citizens? And sometimes
functional aspect of
exactly
it, yeah.
functional aspects. So you can't only look at the cost of the surgery, but if a person returns to work, is paying taxes, is no longer a burden on his family, is that cost effective as opposed to sitting at home taking nitroglycerin? And there have also been things that we've identified. In fact, recently the young skater who had the left main coronary artery lesion who died, that's been very well identified, but those people die at a rate of at least 20% per year. So in 5 years, all of them are dead. If you do surgery on those people, that young man, for example, had that been discovered prior to his unfortunate death, could have been saved.
What do you think about the argument that coronary artery disease is by and large a disease of lifestyle and related to Western diet and smoking and unhealthful habits, and really doing surgery just to take care of the end results of the process?
Well, I think that's a good bit of truth in that. Problem is, these people don't drink enough red wine.
I'm very interested in that. I mean, it's fascinating. You own a winery. Tell us about the wine situation, because I went to school in France, actually. And I know for a fact that the French people drink much more wine than we do. I mean, they don't drink hard liquor, but they drink a lot of wine. But the incidence of coronary artery disease is lower than in the States.
That's true, and it's been identified in terms of the French paradox. I mean, they eat,
They smoke, they
smoke, and
Yes.
and yet they have a much lower incidence of coronary artery disease. And in fact, in the extract of the skin of red grapes, there's a compound, nitric oxide, that essentially has a very, very salutary effect on the vessels, both peripheral and coronary. It decreases the cholesterol, increases the HDL, decreases platelet adhesiveness, and causes a prolonged relaxation of the smooth muscle of the vessels, which causes them to carry more flow and not constrict.
Yeah, and actually I'm sure that there's a difference in terms of if you drink wine or you smoke cigar like George Burns for the fun of it, and it's like a cultural form of delicacy. It's very different from having a dozen of six-packs, watching TV alone and eating a frozen TV dinner. Because I'm just saying that if it's a happy social kind of gathering and you drink and you eat is different than drinking solitarily and being compulsive about it. Would you think so?
No, I think certainly that is true, and I think the mindset has a lot to do with the development of diseases.
I agree with you.
But I don't think we want to go on record saying a happy drunk is less likely to have problems. No. But I think one aspect in France, like you said, so many of these things we don't know all the reasons for, because they also eat healthier diets until recently with the advent of fast food from America there. But they tend to walk more. Like you said, they have a much more relaxed lifestyle. And I think the myth is we're never going to totally stop coronary artery disease or vascular disease from happening, but the idea is that you can prolong the period of time before you get it. And so I think that not smoking, reducing stress in our life, eating a healthier diet, there's no question that that will definitely help people get the disease later in life, but I don't think you can ever say it'll totally stop. And if you try and compare it to earlier years, you got to remember that the lifespans of people, because of other diseases that we've now conquered, like tuberculosis and anything associated with sanitary conditions, the average person now lives to the age of almost 80. If you go back to the turn of the century, it was 35. Well, if you die early enough, you don't have heart disease. So I think that we're not going to become obsolete. We'll just operate on older people. And drink from
Actually, I was interviewing a very good cardiologist from Nigeria, and he said that in Nigeria, coronary artery disease is exceedingly rare. So it has to be has something to do with the way we live.
Well, it's also more than lifestyle. In those situations, you have to remember it's also sort of a natural selection process. If you have a country where people, for example, die of childhood diseases far more than we do, nature by the process selects out sicker and weaker individuals. So you don't see a lot of people, for example, with very severe diabetes in a country like that, or people who have congenital heart disease, those sort of things. So we have to sometimes not just look at the lifestyle, but also who gets to survive to older age.
Yeah, that's very true.
So that's an important
Now, I
component.
interviewed another physician. I thought it was very interesting. He's from England, of course, and he says that up to 70-75% of Americans are overweight. And he proposed that we impose a 10% tax on fat, so that people have to be forced to buy produce. I thought it was pretty innovative. What do you think? You might comment on that?
I think that's a very socialistic perspective.
Okay. And like somebody pointed out, when they subtracted the time people spent jogging and the time that they added to their life, that you got something like an extra half an hour. So that, you know, you have to put things in perspective. Plus things you can't change, like your genetics. They found that group of people in Italy, for example, who had incredibly high cholesterol diets, who all had no coronary artery disease but had a certain gene. So I think we can use moderation. I think too often we intervene with people with such strictness that you not only want to live longer, but you want to enjoy your life as well. So you have to be kind of moderate, because if we have a tax on fat, do we have a tax on cigarettes? Do we have a tax on a bad gene pool? Do you have a tax on people who live in climates such as Los Angeles where they breathe in smog, which is like smoking 8 cigarettes a day? You know, where do you stop it? And, you know, it's a very difficult problem. I think educating the public, like we've done, for example, with cigarette smoking, just by giving people the information and getting it out of there, we have seen a significant reduction in the number of people smoke. Say, compare an American say theater or a dining establishment compared to Europe, you know, where you're in France. The difference now is incredible. You no longer have those smoke-filled nightclubs. So I think education can definitely help.
Again, I would like to go back to the notion that when you smoke and you drink because you're depressed, it's very different than when you smoke and drink in a social setting when you enjoy life. I mean, to me, it's totally different activities.
I think cigarettes are bad for you regardless of the situation.
I'm sure,
But I think the stress, there's no question that stress does play a part in
I think
diseases
so.
we treat.
I really believe that the way we live is very stressful.
Oh, no question about it.
And that is harder to document, because how do you quantitate the effect of stress on different diseases? But I you know, in primary care, and 90% of my patients are stressed out. They don't have a disease. They don't have a heavy-duty pathology, you know, but they have a lot of stresses that cause different kind of symptoms and eventually become a disease.
Oh, absolutely.
And I firmly believe that the genetic part is there, but it's not nearly as important as the environmental effects of different things that are preventable.
And also, stress plays an important part in things like high blood pressure, which we know has
Sure.
an effect on heart
Sure.
disease.
Yeah.
So there's no question that our lifestyles are much different. In fact, they had an article before in one of the New Yorker magazines that had a gravestone for a yuppie. It said, "I ate tofu, I didn't drink, I didn't smoke, and I died anyway." So
That's very true. That's very true. And actually, how do you beat stress? I mean, I'm sure maybe you drink wine, but what do you do to beat stress?
Well, I think a lot of times it's as much as the way we respond to the situation as it is the actual situation. And I think we as Americans have sort of become this instant gratification, I need it now, and we sometimes don't distinguish our wants from real emergencies. So I think sometimes we have to sort of reprogram ourselves to kind of stop and smell the flowers along the way and remember other things are important, like family, friends.
That's wonderful. I love to hear that from a cardiovascular surgeon because, I mean, this is the first time for me I have a chance to talk to a prominent cardiovascular surgery who is poetic in your expression. I think that's perfect because to me, that's one of the purposes of our show is to directly talk to the public and present ourselves as plain folks. Because for a long time I think that we are insulated from that kind of communication. Anyway, I think we're already running out of time. See how fast it is. Half an hour passed by very quickly. I really enjoyed this conversation very much, and I'd like to invite you back in the next segment, the show number 44, so we can continue this very pleasant conversation. I'm Dr. Hung Vu. Our show is America's Healthcare Crisis. This is our 43rd show, and we are talking about the quality issue in cardiovascular surgery. And I'd like to invite you back to listen to our excellent speakers here to talk about the field and some other issues. I'm Dr. Hung Vu. Thank you for watching. Good night.
All right.
Someone, have you ever cared? Do you miss someone? Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near? Do you have